Is that better?
That's better, thanks.
Great. Well, it's great to be with everybody today. So like Kate mentioned, I'm going to be talking about medication use in older adults at kind of a high level, some general principles, which really, when you think about it, is this tango between mitigating risk and maximizing benefit. Before we get started, I just wanted to point out in the context of the 4 M's, the age-friendly health systems, that medications are one of the M's. And of course, we want to be selecting medications that are evidence-based and at the very least are not going to interfere with the other M's. So we don't want to pick things that can impair an older adult's cognition or mobility or get away from their goals of care. So when we think about the quality of prescribing, oftentimes words might come to mind like polypharmacy or drug interactions or renal dosing. And so it can get kind of confusing to really figure out what you're talking about. And so one scheme that I like to use is listed here on the slide. It's these 3 categories that pretty much capture everything that could possibly go wrong with a medication in an older adult's regimen. And so we'll go over just a couple key examples within each of these categories. This is certainly not comprehensive due to time, but we'll just kind of use this as a guiding framework today. So the first category is overuse or unnecessary use. And this is when an older adult is using a medication for which there's no clinical indication. The second category is inappropriate use, and this is defined as medication use where the risk outweighs the benefit, which is sometimes quite hard to know. And historically, we think of this with the Beers criteria. And finally, underuse, which is when an older adult has a condition, say osteoporosis, for which medication is indicated, but for whatever reason, they're not being prescribed that medication. Or when the older adult is prescribed a medication, but they're not adherent for whatever reason. So these are basically the 3 possible ways that medication use can be suboptimal. So think about that when you review a medication list. And for the first 2, they, if they're present, they provide an opportunity for deprescribing, which you've probably heard a lot about in recent years. And we can certainly talk more about that. And I'm happy to come back and give another session just on deprescribing. So let's start with the first category, which is overuse or unnecessary use. And again, this is going to be something that sounds quite obvious, but you would literally match up the medication list with the medical conditions. And if there is a medication that doesn't match a medical condition, then that could be a situation where there's overuse or unnecessary use. And I'm sure you've all seen this in your practice. There are many, many examples. Oftentimes we see this with PPIs or other medications that are just by default continued across settings. What I wanted to talk about today is dietary supplements. Again, this is not comprehensive. I'm just picking this category because it's one that's often overused. And so dietary supplements is a broad term that represents any product that contains a dietary ingredient that are listed here, and they come in every possible dosage form you can imagine. And so just as a thought exercise, think about how many dietary supplement products are sold in the US. So it is 85,000. So this is a super saturated market. And we'll talk about the regulation or lack thereof. And there are a lot of retail sales for dietary supplements. It's important to know and to communicate with your patients and their caregivers about some of these misperceptions about approval and manufacturing of dietary supplements. So generally, no manufacturer regulates or evaluates dietary supplements for effectiveness before they're permitted to be sold. And the FDA, importantly, does not determine whether dietary supplements are both safe and effective. In fact, the FDA typically will only intervene if there's a serious safety concern. So what do older adults think about dietary supplements? AARP did a survey a couple of years ago where they asked older adults, And the vast majority believe that supplements are at least somewhat important for overall health. And again, the vast majority are taking a dietary supplement a few times a week. Diving a little bit deeper now within dietary supplements are memory supplements, which seem to be making a surge in recent years in terms of direct-to-consumer advertising. And so this is a growing portion of the overall market, and they're increasingly being used by older adults. So it's something to be aware of. In this survey by AARP, 11% of respondents said that they're currently taking a supplement to delay the onset of dementia, which is not, there is no evidence to show that we have a supplement that can do that. And 8% said they're currently taking a supplement to reverse dementia. So there's a lot of opportunity here for education, when we're doing medication reconciliation, to make sure that we're asking about these products. And oftentimes it's not an acute risk, but it can be money that the older adult could save and spend on other things. And just to kind of get very specific about Prevagen, which is the one that historically has been the most heavily advertised. This is the protein that is purported to be the active ingredient from a jellyfish. Sounds very exciting and cool. But unfortunately, the evidence is just not there. And so, this is basically just pseudoscience. So buyer beware, stay away from these. And these represent oftentimes overuse of supplements or medications in older adults, and can be some low-hanging fruit for deprescribing. So now switching to the second category of inappropriate use, which again is where the risk outweighs the benefit. Kind of hard to determine as health status changes over time. But when we talk about inappropriate use, we're most often talking about the Beers criteria, which were named after a geriatrician, Mark Beers. They're updated every few years, most recently in 2019. And so we're due for an update probably next year. There are many components to the Beers criteria. When they began, they were literally just one list, but now they encompass much more than just one list. The main components, though, are Table 2, which is the list of drugs that are generally high risk in older adults, and then Table 3, which are drug-disease interactions, which will list a condition, say, for example, here on the slide, dementia or cognitive impairment, and then it will list medications that should generally be avoided in older adults with a given condition. And so one of the themes that you'll quickly pick up on is CNS active medications or psychoactive medications. We have our anticholinergics, benzos, Z drugs for insomnia, and antipsychotics. So that was one drug disease interaction, was in older adults with dementia or cognitive impairment. And similarly, we have another drug disease interaction of older adults who have fallen or have a history of fracture or fall injury. And these are essentially the same medications. And this actually ties directly into our case today, where the patient has a history of recent falls. And so we'd be looking specifically for some of these drugs. And interestingly, the patient today is on some anticholinergic drugs that we'll talk about in just a second. And so this is important because falls, unfortunately, are increasing as the population is aging. And we know kind of what works for fall prevention, but despite that, the prevalence is increasing. And falls, of course, are costly both to the patient's health as well as to the system. And so anticholinergics are mentioned frequently throughout the Beers criteria and commonly come up when you think of inappropriate drugs in older adults. So what are anticholinergic drugs? Well, there are many. And so I think it's most important clinically to be aware of those that are strong anticholinergic drugs. And thankfully, the Beers criteria created this table here that's listed on the slide, Table 7, that are those drugs that have kind of strong anticholinergic properties. There are several other anticholinergic measurement scales, but I think this is probably good enough and for clinical practice just to have close by and to kind of keep in mind some of these drugs. And like I mentioned, our patient today is on a couple of these drugs. So that was the second category. And now to wrap up, the last category is underuse, which could either be where they have an indication, but they're not prescribed, or they're prescribed, but they're non-adherent for whatever reason. And medication non-adherence is a whole huge topic. It's complicated. There are a lot of behavioral factors that are involved, system factors, et cetera. I just wanted to highlight a little bit of work that my team has done recently in JAGS, where we summarized the evidence around pharmacist-led interventions to improve med adherence in older adults. And this work was motivated based on the fact that pharmacists continue to try to work for reimbursement for chronic disease management services on a national level, which is to say through Medicare reimbursement. And so we know that medication adherence to evidence-based drugs is an important quality indicator. So we thought it would be helpful to kind of take stock of what is known, what's the effect, and kind of what's the summary effect of pharmacist-led interventions to improve med adherence in older adults. So we started with about 5,000 studies, and we ended up with 40 that were included. We had a total of 8,800 patients across the 40 studies. And this figure here just shows the effect size. And when it's to the right of 0, it favors the intervention. And down here in red is the summary effect size. You probably notice a couple studies were outliers. We removed those and reran the analysis, and the effect size came down to 0.41, but still in a beneficial direction. And so we concluded that use of pharmacist-led interventions supported by Medicare reimbursement could ensure older adults access to effective med adherence support. And it was kind of exciting to see that the editor wrote this note here with it that says that we provide a strong argument for CMS and other payers to recognize pharmacists as providers so that we can be financially reimbursed as for doing this work. So just to summarize, these are kind of the universe of things that can go wrong for medication use in older adults. We have overuse or unnecessary use, inappropriate use, and underuse. And so when you think about and you approach a medication regimen of an older adult, try to approach it with this framework in mind, and it might be helpful to kind of prioritize what you'd like to do. So I'll stop there and take some questions if there are any.